Good morning, everyone. Each year, AUGS presents the Rayleigh Lecture to honor a person who has contributed to the development and surgical advancement of urogynecology and towards furthering the knowledge and teaching of gynecologic surgery through ongoing AUGS educational programs. Dr. Erin Brennand is a urogynecologist, professor, and department head of OBGYN at the University of Calgary and Alberta Health Sciences, Calgary Zone, a health system serving over 2 million people. Previously, she directed the Calgary Urogyne Fellowship for a decade and remains deeply committed to training the next generation of clinicians and researchers. Her research lies at the intersection of epidemiology, health sciences, and female reproductive tract, addressing pelvic floor disorders, uterine conditions, and surgery on the GU tract. Employing both qualitative and quantitative approaches, her work is grounded in feminist, I'm not going to say that right, challenging traditional notions of good science, questioning the relevance of research for women, and centering lived experience in study design. This career experience informs her topic this morning, Beyond a Bystander, the role of the uterus in repairing pelvic organ prolapse and broader women's health. Please join me in giving Dr. Brennand a warm welcome to AUGS.
Good morning, everyone. It's a privilege to be here today. Thank you to the AUGS Board of Directors for selecting me as this year's Raymond A. Lee Lecturer, and thank you to my colleagues who nominated me. It's truly an honor to speak in memory of someone who left such a profound legacy on our discipline. When I told people that I was preparing a plenary and was calling it Beyond a Bystander, the role of the uterus in repairing POP and broader women's health, a few people smiled politely and asked, "Really? The uterus? Don't you just take that out?" And I get it. For most of medical history, it's been treated as incidental, even disposable once childbearing is complete. But today, I want to make the case that the uterus is not an incidental bystander. It is central. Central to the biomechanics of the pelvic floor, central to women's physiology and their long-term health, and central to women's autonomy. And perhaps most importantly, I hope to convince you that how we frame the options to keep or remove the uterus during prolapse surgery says something about whether we are truly embracing a woman-centered approach to care, or if we're carrying around the echoes of a long history of paternalism in gynecology. Let's go back for a moment and look at how medicine has viewed the uterus and how that shaped the way we treat prolapse. Uterine prolapse is not new. It's been part of women's lives for as long as we have recorded history. The very first descriptions of prolapse are found in the Egyptian papyri, where it was written about the falling of the womb. By the 5th century BCE, Hippocrates described using vaginal supports, pessaries, fashioned out of organic materials like pomegranates. Over time, pessaries evolved from materials such as hammered metals and wax cork in the 16th century to vulcanized rubber in the 19th century, and now to the medical-grade silicone we use today. Pessaries have evolved and endured for over 2 millennia and remain our first-line therapy for prolapse. But while treatments evolved, our understanding of the uterus itself was riddled with myths. In Hippocrates' time, leading physicians felt that the uterus behaved like an animal unto itself, wandering through the body and causing physical and psychological distress due to colliding with other organs. For instance, if it moved up, the uterus caused sluggishness, lack of strength, and vertigo. Should it descend, or prolapse, it caused a sense of choking, loss of speech, and of a woman's sensibility. In fact, the very word hysteria in medical Latin comes from the Greek word hystera, meaning uterus, as both the Greeks and Romans believed that women's mental health was caused by disturbances of the reproductive organs. And so each time we use the term hysterectomy, it is a reflection of this historical bias. Presently, unlike any other operation in modern medicine, this procedure is not named for removal of an organ, but for the removal of a supposed condition, hysteria. For centuries, the anatomy of the uterus was poorly understood, and this was because Roman law forbade dissection of human cadavers, so anatomists relied on human models, believing the uterus contained multiple chambers. In the Middle Ages, some believed that there were 7 uterine cells or chambers, 3 for male fetuses, 3 for female, and 1 in the middle for hermaphrodites. This isn't just a historic curiosity. It reveals how profoundly the female body has been misunderstood. It wasn't until the Renaissance that things began to change. Artists like Da Vinci conducted private dissections, finally depicting the uterus with accuracy. In the 16th century, Vesalius published the first comprehensive description of the female genital tract, including the uterine ligaments. Later, in 1895, Mackenrod, working in Berlin, published his seminal work on the pelvic floor, identifying what we now call the cardinal ligaments. And he wrote with astonishment, "This whole ligamentous apparatus appears so excellent and extensive that it is quite surprising it's not been recognized previously." Building on this, Donald and Fothergill in Manchester advanced the idea that repairing the ligaments of the pelvic floor were the key to treating prolapse. Fothergill refined techniques to shorten and reinforce uterine supports, combining them with anterior and posterior repairs. And for a time, these uterine-sparing procedures were widely performed. But history took a different turn. Around the same time, vaginal hysterectomy was being developed to treat uterine and cervical cancers. A highly successful vaginal hysterectomy was reported in 1861 by Chopin. At that time, most women did not survive such a surgery. So when a little more than a month after the procedure, Chopin presented to the class at the New Orleans School of Medicine with a patient holding her own specimen in her hand, the medical world paid attention. By the early 20th century, improvements in anesthesia and surgical technique made hysterectomy safer. Between 1915 and 1918, Mayo and Bissell published their own techniques, and hysterectomy began to spread as a treatment for prolapse. In fact, in 1937, at the annual meeting of the American Gynecological Society, Baer and colleagues presented on the type of operations performed for uterine prolapse over a 10-year period. They noted that by 1937, vaginal hysterectomy had become the predominant operation, replacing a uterine preserving procedure known as interposition. Comparison of outcomes revealed no differences in cure rates. In fact, hysterectomy came with longer hospital stays, higher complication rates, and even deaths. Still, hysterectomy prevailed. Why? The reasons are as telling as they are unsettling. The belief that removing the uterus would prevent recurrence, despite a lack of evidence. The procedure doubled as a sterilization, reflecting social norms of controlling reproduction. Hysterectomy was framed as cancer prevention, even for women at low risk. And underpinning it all, a cultural conviction that the uterus caused women's psychological disturbances, back to the concept of hysteria. Simply put, this shift was not rooted in science. It was rooted in societal values and bias. And as hysterectomy became normalized, it was passed down from teacher to trainee, enshrined in textbooks and cemented into surgical dogma. The hidden curriculum taught generations of surgeons that the uterus was disposable, that removing it was better medicine. And here lies the uncomfortable truth. It was never about anatomy or recurrence. It was about how medicine and society saw women. The uterus was only valued for reproduction. Once a woman was finished with it, finished with her childbearing, her uterus was seen as redundant, even dangerous, disposable. So fast forward to the 2010s, when academics in urogynecology once again began to challenge the liberal use of hysterectomy in the treatment of prolapse. These individuals realized that prolapse is not a problem of the uterus itself. Rather, it's a problem of support, of ligaments, fascia, connective tissue. During that period, several pivotal studies were published. Much of the momentum came from the Netherlands. For example, Vivian Dietz and colleagues published comparative studies examining vaginal hysterectomy and suspension versus sacrosinus hysterpexy. This was followed by René de Tollenaer's landmark SAVE-U trial in 2015, which demonstrated non-inferiority of hysteropexy. And then Sasha Schulten's 5-year follow-up of SAVE-U in 2019, which demonstrated less apical prolapse recurrence and a higher rate of composite success following uterine preserving surgery when compared to hysterectomy. Around the same time, Kate Merriweather and colleagues' systematic review and meta-analysis compared uterine preserving surgeries to their analogous hysterectomy-based procedures. Their manuscript showed a consistent pattern. Uterine preserving procedures had shorter operating times, less blood loss, shorter hospital stays, and lower rates of mesh exposure when mesh was used. Importantly, there were no clear short-term advantages in prolapse cure for routine hysterectomy. This created not only clinical, but pragmatic economic and health services utilization grounds to preserve the uterus. And it wasn't just original research shaping the conversation. Editorials and opinion pieces began to appear, signaling a real academic debate. I vividly remember reading Barry O'Reilly's 2018 opinion piece in the International Urogynecology Journal. He argued that the uterus is not only an innocent bystander, but in fact a keystone in the stability of pelvic organ support. For those of you that don't know, a keystone is the wedge-shaped stone at the top of an archway that locks all the other stones in place. And if removed, the entire arch falls apart. That analogy really stuck with me and was a spark of inspiration for my own clinical practice, shaping the direction of my research portfolio. In the years since then, further research has sharpened the debate, with Olivia Chang validating instruments to measure how women value their uterus, qualitative studies such as those by Anna Frick and Kaylee Ramage, examining both physician and patient perspectives on the decisions to preserve or remove the organ. And as recently as last month, Olivia Chang and colleagues published findings in the American Journal of Obstetrics and Gynecology on surgical retreatment rates after native tissue apical prolapse surgery with hysterectomy versus hysteropexy. They reported that while approximately 3% of patients underwent subsequent hysterectomy following their uterine preserving surgery, likely for heterogeneous reasons not fully captured in administrative data, there was no significant difference in prolapse retreatment risk between the two approaches over 5 years. These real-world results further reinforce that hysterectomy is not required to ensure the durability of prolapse repair. And so taken together, the body of work from the last 5 years consistently underscores the same message. When asked, many women want to retain their uterus, citing reasons from body image to sexual function and to personal identity, and sometimes just the desire to avoid removing an otherwise healthy organ. And because safety and efficacy profiles are comparable, the bottom line is clear. There's no single right operation. The optimal procedure is the one that best aligns with the patient's values, determined through shared decision-making. So let's talk about why uterine preservation makes sense from a biomechanical perspective. As I've said already, apical prolapse isn't really a problem with the uterus. It's a problem of the supports that hold it in place. Over years, many decades, repetitive strain stretches the uterosacral and cardinal ligaments, a bit like an elastic band that's been pulled too many times. Imaging studies have shown that in women with prolapse, these ligaments aren't just longer at rest, they also stretch more under load. That tells us that their elastic limit has been exceeded. They can't recoil the way that they once did. And here's where the biomechanics comes in. When we perform a hysterectomy, we divide those exact ligaments, the primary supports of the uterus, then try to recreate them by stitching the vaginal vault to whatever structures remain. Biomechanical research suggests this is a downgrade. By removing the uterus, we will lose the continuity of the ligamentous attachments and the extracellular matrix. The result? Vaginal tissue that's stiffer, less elastic, and more prone to maladaptive remodeling. All factors that set the stage for recurrence. By contrast, if we keep the uterus, we get to use the body's own engineering. Those ligaments may be stretched, but they're still load-bearing structures. Uterine suspension procedures allow us to incorporate them into the repair and offload tension in a way that may actually promote their remodeling and recovery of strength. And this is where John Delancey's trapdoor model really helps us see what's going on. If we picture the anterior wall, it's a hinged door. The hinge of that door is formed by the uterosacral and cardinal ligaments. They're what keeps the door supported and properly tensioned. When those ligaments stretch or weaken, the hinge slackens and the whole door starts to swing downwards. And as it does, the upper apical portion of the anterior wall descends, pulling the bladder and the rest of the anterior wall with it. We know that's how a cystocele develops, and to a lesser degree, the same mechanism can contribute to rectoceles. What's powerful about this model is that it connects anatomy to mechanics in a way that is measurable. MRI and biomechanical studies have confirmed it. More than half the size of an anterior wall prolapse can be explained purely by how far the apex has descended. In other words, prolapse is fundamentally about the loss of apical support. And once support loosens, the hinge gives way and the rest follows. We also can't forget about the cervix itself. Cadaveric work has shown that sutures placed at the cervix withstand higher maximal loads than sutures placed in the vaginal vault. In other words, the cervix is a biomechanically superior anchor than a vaginal cuff. It is a true keystone in pelvic architecture. And the use of it in suspension allows us to restore the apex with the strongest, most natural anchor point. Pelvic forces move along their original axis through intact ligamentous supports instead of being redirected to weaker planes of tissue. So when we put it all together, to me, the story is clear. Hysterectomy removes the strongest supports in the system and replaces them with weaker ones. Preservation keeps supports intact, preventing the walls of the vagina to swing downwards. It lets us work with the body's own design and gives our repairs a stronger chance of holding. I'd like to tell you a story about what happened where I practice, Calgary, Alberta, here in Canada. Just over 10 years ago, when I started my career, fewer than 5% of prolapse surgeries performed by our urogynecology group preserved the uterus. Those rare cases, they usually happened because the patient had the kind of pelvis you just didn't want to find yourself in. Early in my practice, I noticed a pattern. Women were coming to me for second opinions. They'd already had thorough consults with my urogynecology colleagues, but they hadn't gone ahead with surgery because they weren't sure about losing their uterus. A new face in the urogynecology group meant a new chance to ask, are there other options for me? And at the same time, the academic literature was beginning to seriously question hysterectomy as the default. And so I started offering uterine preserving surgery more openly, but with one important caveat. We didn't have local data about success rates. And as someone who is both a surgeon and a researcher, that didn't seem right to me. We needed evidence from our own setting. But here's the problem. The so-called gold standard in clinical research would have been a randomized trial. Hysterectomy versus preservation. Flip a coin and your uterus might be gone. That struck myself and my team as fundamentally unethical. For centuries, women have had their bodily autonomy stripped away by medicine. Were we really going to reproduce that harm just to generate evidence? And practically speaking, who would even sign up for that study? So we did it differently. We designed the HUP study, hysterectomy versus uterine preserving prolapse surgery. We asked ourselves, as primarily a group of women researchers, how would we want to be approached with respect to participation in research like this? And so women self-selected their surgical path. And then, using advanced statistical methods, we emulated the conditions of a randomized trial. We paired that with longitudinal qualitative arms of research to understand why women chose as they did. The HUP study was evidence built on valuing women's autonomy. So what did we find? Well, we started thinking that maybe 25 to 30% of women would choose preservation. We expected it to be the younger patients. Instead, almost 50% did, across all ages, even into their 70s and 80s. Our outcomes? Equivalent, or actually a little better with preservation. Apical recurrence beyond our predetermined definition of cure, which was 50% of vaginal length, at 1 year was 17.2% after hysterectomy versus 7.5% with uterine preservation. And this persisted even with our advanced modeling for a statistically significant adjusted relative risk. Our analysis of individual components of post-operative POP-Q scores showed more elevation not only of the apex, but also the anterior and posterior walls, in keeping with Delancey's trapdoor model. Preservation also meant shorter surgeries, shorter hospital stays, less opioid use, and fewer complications. At 1 year, composite risk recurrence was lower in uterine preservation, driven by better anatomic results. Functional outcomes, no meaningful differences. But the most important finding wasn't clinical. It was existential. When given a real choice, half of women chose to keep their uterus. Our qualitative data explained why. Women's decisions were complex, shaped by clinical facts, yes, but also by deeply personal values. Most came in already knowing that hysterectomy was the norm. Few even knew that uterine preserving options existed until their surgeon told them. And even after standardized counseling, some still believed that hysterectomy must be better. It must have lower recurrence. It must be more definitive. Because that's what friends, family doctors, or even subtle cues from their surgeon was suggesting. It was a sobering reminder that information alone doesn't undo generations of social norms. For women who chose to keep their uterus, many described a less is more approach. They didn't want their bodies disturbed. For others, they described a deep personal attachment to their uterus, associating it with femininity, their experiences in the past of motherhood, and their personal identity. Often these women did not know how much the organ meant to them until they were empowered to make a decision about how it was treated during surgery. When the study was complete, it shifted practice in Calgary. Surgeons saw for themselves that their outcomes were equivalent, and some recognized their own implicit biases towards hysterectomy. As a group, we began asking, what system-level forces push us towards hysterectomy? We launched a knowledge-sharing campaign, presented across the province, and have advocated that uterine-preserving prolapse surgery should be reimbursed on par with hysterectomy-based repairs. And here's where we are now. In Calgary today, our practice is about 40-60, favoring uterine preservation. That's a 12-fold increase in a decade, a true culture shift. And it happened because we asked the question differently, and because we grounded the research in a feminist epistemology. So far, I've talked about surgical outcomes, the trapdoor model, and what women actually choose when given the option. But there's another dimension here. one that I think is even more unsettling. And that is women's long-term health years after their encounter with a urogynecologist is long behind them. Like many of you, I was taught in residency that if the ovaries are left in, hysterectomy had no long-term health consequences. The only risks were the immediate surgical ones: bleeding, infection, injury to nearby structures. The hidden curriculum was clear. The uterus was biologically incidental once childbearing was over. And for a long time, I repeated that message to patients. Sometimes I feel embarrassed when I think of all the women I reassured, telling them that hysterectomy was a neutral choice, that it wouldn't change their health in the decades to come. But here's the thing. We didn't have the data. That was our blind spot. And when medicine doesn't have the data, it falls back on history, on bias, on the comfort of the status quo. And the status quo said, the uterus doesn't matter. Except now, the evidence tells us that's wrong. Epidemiologic studies show a consistent pattern. Women who undergo hysterectomy, even with their ovaries preserved, have higher risks of cardiovascular disease, metabolic syndrome, osteoporosis, dementia, and neurologic disease. The younger the patient is, the higher these risks. And while these studies all come with the usual caveats of surveillance bias and confounding by indication, the signal is strong enough that we need to pay attention. So my team wanted to push this further. We used Alberta's population-based data, over 4 million people in the province, universal health care, and 20 years of follow-up. We focused on 1 million younger women, ages 20 to 39, to avoid missing hysterectomies outside the capture window. We employed multiple modeling techniques. We controlled for indication. And what we saw was striking. Among nearly 50,000 women who had hysterectomy with ovarian conservation, the incidence of cardiometabolic disease was more than double that of women who kept their uterus. 285 cases per 10,000 person years versus 127. With modeling, the adjusted hazard ratio was 1.33, a 33% higher risk of developing cardiometabolic disease in the subsequent 20 years. And this wasn't just one outcome driving the signal. We saw consistent elevations in chronic kidney disease, ischemic heart disease, fatty liver, and stroke. These associations held up across multiple models, and they didn't fade over time. So what's going on? The leading hypothesis is biological. During hysterectomy, we transect the uterine arteries, a key source of collateral blood supply to the ovaries. And with that gone, ovarian perfusion is reduced. The ovaries don't fail immediately, but over time, their endocrine function declines more quickly. Estrogen dips sooner than expected. And while it may be not enough to trigger hot flashes, it's enough to accelerate vascular changes, lipid dysregulation, and downstream cardiometabolic risk. This is not new. The first hints of it were published back in the 1980s. But the data are rapidly accumulating in the last 5 years, and the message is unavoidable. Hysterectomy is not a benign operation before menopause. It changes the trajectory of women's health. And that should make us pause as urogynecologists, because when we remove the uterus, we may be doing more than treating prolapse. We may be increasing a woman's risk of chronic disease for decades to come. And if we don't tell women that, we're stripping them of the chance to weigh those risks, to consider alternatives, and to take proactive steps to mitigate the new risk factors they've just acquired. So for premenopausal women especially, preserving the uterus isn't just about pelvic support or personal preference. It may be a way of safeguarding long-term cardiometabolic health. So where does this leave us? First, every woman deserves to know that preserving her uterus is an option. True informed consent isn't about offering what we prefer or what we've been trained to do. It's about giving women the full picture, putting both choices on the table, and giving women the chance to decide for themselves. Second, as surgeons, we need to interrogate our own habits and assumptions. We know surgeon preference weighs heavily on patient decisions. If our default is still to recommend hysterectomy, we have to ask, is that grounded in evidence, or are we simply repeating the traditions handed down to us? Third, if uterine-preserving techniques feel unfamiliar, the answer isn't to just avoid them or not present them as an option. The answer is to upskill, seek training, learn the techniques, expand your surgical repertoire so that your skill set keeps pace with our patients' needs and preferences. And encouragingly, we are beginning to see the field move in this direction. The 2025 AUGS Clinical Practice Statement on the role of uterine preservation at the time of POP surgery concludes, uterine preserving surgery should be a surgical option for all patients considering surgical treatment for symptomatic pelvic organ prolapse, unless contraindication exists. This is an important milestone, a recognition that preservation is not fringe, but mainstream evidence-based care. Because this is bigger than technique. This is about autonomy. It's about protecting women's long-term health. And it's about dismantling the quiet paternalism that has shaped gynecology's history. The uterus is not incidental. It is structural, it is functional, and it is meaningful to many of our patients. Honoring that is not just feminist medicine, it is good medicine. So let's move forward differently. Let's center women's voices, keep preservation on the table as a real choice, and commit to building a specialty that listens, respects, and evolves. Thank you.